to introduce Professor Gary Freed. You've seen his distinguished curriculum vitae in the notice of meeting. He's had a career in pediatrics, in ethics, in equality and diversity, and in health policy management. And he's also, as he's told us, did once spend a sabbatical in London in the immunization section of the Department of Health. So visiting London is not foreign to him, but visiting London in this guise maybe is a little unusual. I was explaining to him about the Zoom webinar series that we've had, and it's certainly, he's provided us with a provocative and interesting title, and I'm going to hand over to him directly.
Great. Thank you so much, David. And thank you very much for inviting me. Fiona Sims is a colleague of mine. We worked together at the Brookdale Institute in Jerusalem on a health advisory committee. And like David said, I've spent 6 months in your fair city, living up in Woodside Park on the High Barnet branch of the Northern Line. And it was an absolutely wonderful experience. So thank you again for having me. I'm going to share my screen now. And ideally in one moment, you should now be able to see the full screen being a slide. Is that correct?
That is correct.
Okay, wonderful. So I'm going to speak to you now about something that probably threw many of you off, because I'm going to speak to you about the impact of aging on the delivery of healthcare to children. Most people think about aging and they think about, oh my God, how are we going to take care of all these old people that are now, taking over our society and creating, such issues within the healthcare system. But because I'm a pediatrician, I actually don't care about old people. I care about children. I like many old people, but I don't necessarily care about them with regard to their health. So I think that my premise here is that when we're so focused on the aging and the aged, is there a chance we've taken our eye off the ball a little bit with regard to the care of children? And if we have, is there any impact on the care of children when we do that? And that's what we're going to explore today, or this evening. I want to throw out a quick disclaimer. Just in case any of you couldn't tell by my accent, I am an American, but unlike many Americans, I actually do understand there are other healthcare systems in the world. And sorry to disappoint everyone, but I'm not going to suggest that everyone do things just like America. I also want to make the point that I'm only showing data. They're going to be presented at a 10,000 foot, not meter level, because I know that's one thing that we share is the imperial measurement system. There is more detail available on all of the things I'm going to talk about, and probably around 50 published articles that deal with the issues that I'm going to raise. So the point here is that I'm only showing data. I'm not really editorializing necessarily on what it means, but I think it's important that we make policy decisions based on data, not on anecdote or not on rhetoric. And I also want to make it clear that I'm under no illusion that what I'm going to be presenting today is rocket science. But in fact, I believe sometimes very straightforward information can help us to make better decisions about how we structure our healthcare systems and make sure we take care of everyone within our populations. My goals in doing this kind of work are to basically ask questions that can help us or that may benefit children's health. Again, to provide information, simply to help healthcare systems make better decisions. Not necessarily, and by no means do I think it's my place to tell any country how they should run their healthcare system. That even if I wanted to do that, no one would listen. So that's not what I'm here for. And I want to encourage and support those who conduct research on health services for children, because quite honestly, the vast majority of research that goes on into the performance of healthcare systems, into quality of care, into economic analyses within healthcare systems exclusively focuses on adults and often focuses on seniors. It's uncommon relatively for that work to be focused on kids. And so I want to encourage anyone in the audience who wants to do this kind of work to contact me, and I'd be happy to help support them and connect them in any way that I can. And I believe that those data that we can create, ideally in as unbiased a fashion as possible, can assist us in finding solutions to structural issues within all of our healthcare systems. Now, to start, I think that it's clear that a lot of people throw around a lot of different data, and they oftentimes, when they're dealing with information about a healthcare system and a healthcare system's performance, will often say, well, I'm not really sure how valid this is, but it's the best we have. My feeling is if we're going to start out with a premise by saying, I don't know how valid this is, we should just stop there, because the stakes are too high to be able to excuse or allow poor quality data to help drive decision making. And here's a cartoon from America. It's a cartoon series called Dilbert. And the boss is saying, so do you have those budget numbers from last month? And he says, well, they're totally inaccurate. He says, I know, but they're the only numbers we have. He says, actually, we have infinite inaccurate numbers to choose from. He said, well, let's keep those in our back pocket in case we need them. So I'll encrypt them so no one else can use them. The premise is, again, if we don't think things are accurate, we shouldn't be using them. So I'm going to share some information with you that I do believe is accurate. But first, I want to give you a little bit of background to what I'm going to speak about. So as advertised, I'm going to be talking about this change in demography. And I want to say what I mean by that. All Western industrialized nations are aging. And in that context, most of them, not all of them, have a relatively stable child population, meaning, let's say in America, we have roughly the same number of children today than we had 40 years ago. Now, they're not the same children, obviously, but roughly the same number of kids. The difference is that the population or the number of older people in our population is increasing because people don't die. They hang around, so that the number of adults and the elderly is going up. If the child, for those of you who are good at math, it should be relatively obvious. If the child population is stable and the adult and senior population is increasing, children become a smaller fraction or proportion of the population. So we can have the same number of kids, but just they're a smaller fraction of the population. The other thing that's important to keep in mind is that even though we focus a lot on adults with chronic illness, adults with hypertension, adults with diabetes, that's where a big hunk of our focus on healthcare spending and on healthcare organization goes, we tend to forget that there's more children alive with chronic illness today in all of our countries than have ever been alive before. For the very simple reason is we now save these children. They all used to die, but now we save kids that have type 1 diabetes, that have cystic fibrosis, that have a myriad of congenital diseases. So we do have more children alive with chronic illness, but in terms of our primary care systems, we rarely think about primary care management of childhood chronic illness, where we focus tremendously on primary care management of adult conditions, adult chronic conditions. So also in background, I want to let y'all know that I'm very aware we have different primary care systems between our two countries. Just in case, to make sure you understand where I'm coming from, in the United States, we have GPs, but GPs are not the only primary care physicians in our healthcare system. We also have primary care pediatricians for kids, and we have primary care internal medicine for adults. Patients can choose which doctor they want to see. It's not a referral to see a pediatrician or an adult internal medicine doctor. Those are simply choices that people can make with regard to primary care. This is obviously in contrast to the UK, to Australia, to the Netherlands and other countries where the GP system is is such that primary care is only provided by GPs, and they are the backbone of the entire healthcare system. And I will just parenthetically say, if there's any GPs on this call, I think you have the hardest job in the world. And I think you are the unsung heroes in many respects of these healthcare systems, because you have to stay on top of everything. And that's now going to be some of the focus of what I'm going to talk about. And again, I want to make it clear, I am not here to tell you you should have a US healthcare system. That is not the point of anything that I'm going to discuss. Now, the reason I got started in looking at this impact of aging on the delivery of healthcare to children is because of some workforce studies that I was doing in the United States for the American Board of Pediatrics, which is kind of like your Royal College. And what I was doing was I was looking at who was providing care for children in America and how that changed over time, because that has both workforce implications, how many of different types of doctors that we need, and it also has training implications for who we need to train and what kind of training they get. So these initial studies in the United States were looking at, has primary care, or the providers of primary care, has that changed in the United States over the last several decades? As I said before, children in the United States can get primary care from either GPs or from general pediatricians. And we found that as the demography of the United States changed, almost in lockstep did the demography of GP patients. Meaning that as children became a smaller proportion of the United States population, children then became a smaller proportion of GP visits. Now, in some respects, this is intuitively obvious because GPs have a certain number of patients they have in their panel. If people don't die, which I told you they're doing less and less, GPs will add fewer new patients into their panels so that the proportion of new patients or children becomes less over time. Now in America, this actually resulted in some GPs seeing many fewer children and deciding, you know what, I'm not seeing enough kids to make this worth my while. I'm just going to stop seeing kids. And they would limit their practices to people 18 years and older, 25 years and older, some 45 years and older. And that was okay because that was their option. They had the opportunity to do that. But we found it also created somewhat of a crisis in GP training, because for many of the places where GPs, registrars, I think you call them, is that right, registrars, or residents, were doing their apprenticeship training, fewer and fewer children were coming in. So those GP residents in America were seeing fewer and fewer children. So many GP programs started farming out their GP residents, if they could, to pediatric practices to get enough exposure to kids. Now, in America, the fact that GPs were seeing fewer children and a decreased proportion of kids wasn't such a big deal because we had an increasing number of primary care pediatricians over those same 4 to 5 decades. And so anyone that the GPs weren't seeing would be picked up by this increasing number of primary care pediatricians. And just to illustrate that, I'm going to show you a graph of along the, I think my pointer you should be able to see, along the y-axis is the percent of visits for children aged less than 18 years of age. Along the x-axis is year. These blue diamonds are general pediatricians. These red squares are GPs. And you can see that over time, the proportion of visits to general pediatricians increased, and the proportion of visits over the years that went to GPs decreased. In fact, there was a shift in market share. But again, the proportions and the absolute numbers changed as well. The people that weren't being seen by GPs were picked up by the general pediatricians. And that trend has actually continued over time, so that now GPs actually care for only around 17% overall of children in the United States. And they take care of only around 8% of children less than 1 year of age. So this trend is still continuing in the United States, which actually mirrors in many respects the continuous change in demography of our country. Now, I thought this was interesting, but what then kind of caught my eye was a different research question, which was, what happens in countries that are undergoing this same demographic change, but have a GP-only primary care system? And does that change in demography of the population affect GP care, especially in countries where there's not a huge increase in the number of GPs? And so and then additionally, as countries aged demographically, did they continue to focus on the aged, and did that result in missing some issues related to childhood health? And was the primary care management of chronic disease really only a focus on adults, or was anyone thinking about primary care for children when they thought about either acute care, excuse me, preventive care, or chronic care? So what I wanted to start to look at, and I'll tell you in a second where I did this, was has there been a change in GP patient demography in a country with a GP only systems? And if so, was there an impact on the care of children, as GPs saw, or potentially I hypothesized, might see fewer children, both proportionally and in absolute numbers? Would that, just like it did in America, have an impact on GP confidence in the care of children, potentially GP competence in the care of children? And would any of those things then have an impact on parental confidence in GP care of children? And to measure that, would there be any changes in the patterns of care? Would there be any changes in referrals to emergency departments by GPs for minor conditions for children? Would there be efforts on the part of parents to bypass their GP if they lost confidence and go directly to emergency departments? And would there be an increase in specialty referrals if GPs were feeling less comfortable or confident in their care of certain pediatric conditions? So I went to Australia. And Australia, I went there for a sabbatical, but then it turned out, as I'll show you, that some of this was actually pretty interesting stuff. And these were things that no one had ever been thinking about before, because everyone was so focused on how are we going to take care of all these old people. And so it was a different ballgame to start thinking about the impact of demography on GP care. So I ended up spending around 3 years in Australia, starting a research center there to focus on pediatric health policy and pediatric health economics. And I'm going to share with you some of the results of those studies to try and answer some of those questions. In essence, does a change in the demography of a country have a change in the demography of GP practices? And does it have an impact on the way in which GPs deliver care? So just so that you know, I'm not kidding, Australia's population is changing, has changed. This is the proportion of the population for people 0 to 19 years of age. Along the y-axis is the proportion of the population. Along the x-axis is year. What you're seeing here are 3 different age bands of children: 5 to 14 years of age, 15 to 19, and 0 to 4. And you can see clearly that children are becoming, over time, a smaller fraction of the population. So then the next question is, did that play out in GP visits also? So this graph shows you, yes, in a word. We have here along the y-axis, the overall proportion of GP visits. Along the x-axis, we have year, and these represent different age bands. This thing that's going up in a relatively close to linear fashion is the proportion of visits to GPs for people 65 years and older. You can see that's increasing. And you can see for these pediatric age bands down here, you can see they're all going down. So in fact, the change in demography of the country is having an impact on the demography of GP visits. Now, I'm just going to show you quickly, this happened across all age groups of children, and it happened across all states and territories in Australia. Again, along the y-axis is the percent of proportion of GP visits. Along the x-axis is year. Each of these colors represent a different state or territory in Australia. This is for children 0 to 4 years of age. And you can see for every state the proportion of GP visits for kids 0 to 4 years of age is going down. Again, I want to emphasize the absolute number of children in this country increased 11% during this time period. Okay, so Australia had more children, but they became a smaller fraction of GP visits. This is the same graph showing 5 to 14 year of age people. This is again proportion of GP visits. Along the y-axis is percent of visits, x-axis is year. And you can see for every single state and territory in Australia, children becoming a smaller proportion of GP visits. This is for kids 5 to 19 years of age, exact same story. And for those of you who are curious, well, that's just proportions, Dr. Freed, what about absolute numbers of visits? You can see here for the total number of visits from 1996 to 2010, the trends continued. This is just when this study was done. Along the y-axis is the absolute number of GP visits in the country. On the x-axis is year. This is people 20 to 64 years of age. You can see the absolute number of visits increasing. This is people 65 years of age, the absolute number of visits increasing. And these are the 3 pediatric age bands. And for 2 of the 3, it's gone down. For 1, it's relatively remained the same. But remember, there's 11% more children in absolute numbers during this time period. And that's not reflected in any increase, actually a decrease in absolute number of visits. I'm going to let that sink in for a second. And now let's talk about what are the potential implications of that. So then the question arises, as GPs see fewer and fewer children, does that impact, as it did in America actually, the comfort level of GPs with pediatric issues? Does it affect the competence of GPs in the care of children with chronic illness? Does the lack of exposure or the decreased exposure to children's issues result in delayed recognition of developmental delay or other problems? And does some of this result in increased referrals to pediatricians and or increased referrals to emergency departments for minor low urgency conditions that GPs used to handle on their own? So we studied that. And I'm just going to kind of cut to the chase because we only have a limited amount of time here and just share with you some results. So we studied ED presentations, emergency department presentations across the country in Australia and within each state and territory. And this slide only represents what were called low urgency conditions, meaning when kids or adults come to the emergency department in Australia, and I'm sure there's a similar system in the UK, there's a triage system that creates a level of urgency based on the symptomatology and the condition. So this is data for low urgency conditions. We found, interestingly, actually, that 20% of children presenting, even though Australia will tell you everyone has a primary care doctor in their system, 20% of kids did not have a regular source of primary care. I don't know what the proportion is in the UK, but I'm sure there is a certain proportion, even though everyone is registered in the NHS. We found that for those presenting with low urgency conditions, Only 43% tried to make a GP appointment before they came to the ED. These again are low urgency conditions. Of those who tried, 70% made an appointment, but 2/3 of them were sent to the ED by the GP, again, for low urgency conditions. For those who didn't contact a GP prior to the emergency department, around 40% didn't think the appointment would be available. 14% said the GP would just send them to the ED anyway, which we just saw 2/3 of them did. And 48% of those parents thought the problem was too serious to wait, again, even though they were low urgency conditions. So we then found out that those 2/3 of kids who went to the GP who got referred, we wanted to learn more about those. So one level of designation was this low urgency from that triage category, but then there's other ways of using claims data to then sort those into what's called primary care type visits. Something could be low urgency, but still require an ED visit. So we found out among those that the GPs referred to the emergency department, 74% of those low urgency presentations met definitions for a primary care type visit. Things that GPs who developed this system felt should have been cared for by GPs and not warranted a referral. And for those children 0 to 4 years of age, those who were category 4 and 5, which are the low urgency presentations, 90% of those met the definition of a primary care type visit, meaning that GPs were referring a significant number of primary care type visits to an emergency department for evaluation. We then studied GP residents. And because we knew that from speaking with the Royal Australasian College of General Practitioners and their other training programs, that the apprenticeship is where a lot of GP residents or registrars would get their training. And there was a system of what walks in the door is what gets seen. And if fewer children are walking in the door, we hypothesized that that meant that they were seeing fewer kids. And that actually turned out to be true. And there was no specific criteria for how many children GP residents needed to see during their training. If you're a surgical resident, you have to take out like so many gallbladders, right? Like to graduate. But you didn't have to see a certain number of children. And we saw over time that these pediatric residents were seeing fewer and fewer children each year because a smaller proportion of kids were coming into the GP practices. We then looked at what type of care those residents provided. We found that they referred pediatric patients at 2 to 3 times the rate of adult patients. They had relatively uncommon, I guess it's even fair to say rare, exposure to common behavioral concerns of patients. And then they also had diminished inpatient pediatric experiences as well. Then we looked at, okay, well, that's unfortunate, but does this also play out in the continuing education of GPs who are already out in practice, who are doing continuing education? And does this increased proportion of care of adults play out in that domain as well? And we found out when we worked with the Australasian College of General Practice that there was an overall increase in continuing education offerings over the decade that we studied. But interestingly, there was a 30% decrease in the programs that were focused on children over the past decade, with a commensurate increase in programs focused on chronic illness in adults. Now, let me be the first to say, let me just say again and reemphasize, this is not a blame a GP issue. GPs have the hardest job in the world. I can't imagine taking care of an increasing number of elderly people with multiple complex problems and multiple chronic illnesses. And I totally understand the need for increased education and increased focus on those patients, because that's a tough, tough haul. The issue, though, is even understanding that and recognizing the importance of that and recognizing the almost impossible job of a GP, how can we still create the opportunities for GPs to remain comfortable and confident in the care of children and competent in the care of children? Now, this was my effort in Australia. And again, the data behind all of these studies is easily retrievable. It's all in the peer-reviewed literature. At the same time, as you know, the UK has a similar system to Australia with regard to GP and primary care. And so there were colleagues of mine at Imperial and King's College who did very similar studies and also published them in the peer-reviewed literature. And there were similar findings to those in Australia with regard to increased referrals to emergency departments, increased referrals for specialty care for children by GPs, and also some issues with regard to continued confidence of both parents as well as the GPs in their care of children. So the implications of these findings are that both we have to get a sense of what can we do to be able to help right the ship with regard to the current care of children. The goal, again, is not to change the healthcare system, because the current workforce, even if I was to say to you, oh, well, your solution is to have primary care pediatricians, it's not, because that's not the way the healthcare system, either in Australia or the UK, is set up. That's not the way your workforce is constructed. That's not the goal. The goal is, how do we do our best to ensure that how do we help GPs to do the almost impossible job that's in front of them? And so one thing that we found in Australia, at least, was, like I said, there was no specific number of children to be seen by any of the residents when they were in training, and a real resistance to change anything and to have requirements on the part of the Royal Australasian College. But regardless, this was actually creating some unseen crises in the healthcare system. While everybody was focused on adults, it turned out that the actual numbers in proportion, or the greatest proportion of growth of ED visits, was actually happening in children, not in adults. And so there were issues with ED capacity, and also issues with pediatric specialty referral, because as GPs were referring more and more children for whom they used to be able to provide care, it was overloading the pediatric referral system because the workforce wasn't there to handle it. And it created longer and longer waiting times for pediatric specialty care in Australia. And it's my understanding from my colleagues in the UK that similar things were happening in your country, while everyone was really focused on how are we going to take care of all these old people. So it meant that there were some real decisions that had to be made, and some kind of hard decisions if in fact something was going to be done. And it was going to require at least a little bit of focus on the pediatric healthcare system, which was, at least in Australia where I studied it, was breaking at the seams. So it turns out that we've had greater conversations with those colleagues in the UK who had done similar studies here. And we now have worked on, in Australia, and my colleagues in the UK have done it in the UK, some interventions to try and help. Again, the goal is not to change the healthcare system, but to be able to help GPs to continue to focus on children while they're having to devote more and more time to focus on adults. So we have programs in each of these countries, Australia and the UK, where we are nesting pediatricians in GP practices, usually about a day a week, where they can do shared care with GPs. GPs can become more comfortable and confident in the care of children, and they can lead case discussions where GPs can bring clinical questions. Ideally, this would be for somewhere between 8 and 12 months, which is what we've done this so far. And then the GPs will go back to not having pediatricians in their practices, but these are adjunct people to be able to help restore confidence in the care of children. And the impact of placing those pediatricians, even just once a week in these GP practices, has been a decrease in ED referrals from those practices and decreased specialty referrals. We've recently expanded this to 3 states in Australia, but I'm sad to say that there's been no change in resident education in Australia thus far. One of the other things that we are hoping to do in Australia is that GPs can do in that country an extra year of training if they want to, like, say, specialize in obstetrics so that they can still deliver babies, or they can do an extra year of training in geriatric care. We would like to see an option for GPs to do an extra year of training in the care of children, so that they might be the kind of go-to person within their GP practice for the care of children and or to help others. But right now that's been, there has not been movement on that in Australia. Currently, I am doing a sabbatical in the Netherlands, which now that you have left the EU, is the largest country in the EU by population that has a GP system of primary care. And they've never looked at pediatric care either, oddly, because they're really focused on how they're going to take care of all these old people. But they have the same, they do have the same demographic changes. And now I'm looking to see if they have those same changes in the demography of their ED visits. Has that had an impact on acute care, chronic disease management, all the same things, as we did in Australia and was done in the UK. Again, with the goal of creating information to help people make better decisions in the care of children, and hopefully to be able to develop a cadre of individuals within the country who will focus on children's health and the care of children going forward, even as the demography of the country angles more and more to a smaller population of children. And, it's tough. This is another cartoon from America. This says Calvin and Hobbes. He says, the more you know, the harder it is to take decisive action. Once you become informed, you start seeing complexities and shades of gray. You realize that nothing is as clear and as simple as it first appears, and that ultimately knowledge is paralyzing. So he throws away his book and he says, being a man of action, I can't afford to take that risk. He says, you're ignorant, but at least you act on it. The issue here now is that, once we start to peel back that onion or look under the rock and we see that there's some real issues in the care of children, the direction that the care of children is going, we actually have to figure out what we're going to do about it. And it's much easier if we actually never looked, because then we could just focus on the old people. But now we're going to, in all of our countries, the United States is no exception, we focus on old people, but especially in countries that have a GP system of primary care, that demographic change is having a significant impact on primary care. And that trend will continue because the demographic trends are not changing. And unless there's some type of action that's going to occur, we will see a further erosion of the healthcare system as it's designed for children right now, with ever increasing numbers of referrals, longer waiting periods for specialty care, and the emergency department becoming a de facto primary care venue for some of the nation's children. So I'm going to stop there and stop sharing my screen. I imagine I've said some things that have either created questions or disdain or anger on the part of the group. And so now I'm very happy and willing to answer questions. David, you're on mute.
Thank you very much. And yes, you have generated several questions, and I'm going to go through them. First of all, Mervyn, who's himself a pediatrician and works both in the UK and in Israel, asked the question, in pediatric training, in general practice training, there's an attachment to a pediatric department in a hospital in the UK. This increases exposure to pediatrics for general practitioners. It's an option, but it's an option that's quite commonly taken. Does the same apply in Australia? And do you see that as one possible solution?
So Mervyn, thank you for the question. The answer is there are fewer and fewer pediatric placements in Australia available for GPs. I think the more fundamental issue is that hospital-based training is actually not very good for primary care, because what we need our primary care physicians to do is to be able to learn how to do the outpatient management of asthma. We don't need them to learn how to manage asthma in an ICU or an intubated patient. And so I think that by using inpatient care as a crux for training of primary care, we're actually not going to create, I know it sounds crazy, but we need to have primary care doctors who can decide whether or not a murmur is an innocent murmur or not an innocent murmur, not how to take care of tetralogy of Fallot. And by putting, if the only exposure for GPs is hospital-based specialty care, then I think it's better than nothing, but it's not teaching people how to provide primary care.
Right, because that is a long-standing tradition in the UK. That
correct.
That part of primary care training is spent in hospital.
Right.
So it is a significant difference.
I would just suggest that as long as it's part of primary care training, but if it's the only pediatric exposure or the vast majority of pediatric exposure, then it's not really primary care training. And I would contend the same is true for adult care. If those same GP residents only took care of hospitalized adults, we wouldn't say they're ready now to go be a GP.
Right. Okay, then Andrew Zensko, who is also a pediatrician, and he regards it as a very clear exposition of something he's observed himself. He wants to ask about evidence that the quality of care has changed for better or worse for children with the primary care, in the primary care issues.
So that's a great question. In Australia, we did do studies regarding changes in inappropriate use of antibiotics, as well as other medications that either are not recommended for use in children, but are recommended for use in adults. And we also saw an erosion in inappropriate, well, we saw inappropriate antibiotic prescribing increase for kids. And we saw an increase in what would be called low value care for children. So, so yes, quality of care is changing. And if you consider quality of care also referral to emergency departments and specialty care for conditions that should be managed in primary care, then I'd say, yes, that's an erosion as well. And I guess the last part of that is, David, will you?
Yeah. The answer in the UK is why not GPs for children? Is this just a political issue in the UK? I'm not sure that.
I would say that right now there's, I think, at least in Australia, and I can't speak to the UK, the Royal Australasian College of GPs felt under siege in many respects. And, everyone has a complaint against GPs. And I think the point here is that GPs are the heroes of the healthcare system. It's really hard to be a GP. And whether or not we have GP opportunities for GPs to learn more about kids or how we do it, I think a lot of it is politics. I mean, health is politics. I mean, that's not a secret. We don't like to say that out loud, but healthcare is politics in many respects.
Right. We're coming to the politics. There's, of course, internal issues of difference of opinion. And there are two contrasting questions put forward, one by Lawrence Buckman, who's a general practitioner, and he asks how you can get more pediatric training into a crowded curriculum. And that inevitably there is, if they're more elderly and the illnesses, more illnesses with them, rather than children's health, the proportion of pediatric training, it's inevitable for all in pediatric training. But on the other hand, Mark Clarfield, who's a geriatrician from Israel, says the issue of decreasing skills in pediatrics is okay. He understands, but he's uncomfortable with the implication that this is actually caused by the increasing number of older people.
So
two contrasting views.
Yeah, I think, Mark, you may have missed where I showed the link between the change in demography and the demography of GP practices. It's not just the demography of a country, it's the demography of the practice that's having that, that implication. And if you want to talk offline, I'm happy to share that information with you. To get to Dr. Buckman's comment, I feel for GP training. I think that it's going to be really hard unless there's going to be some kind of carve out with a minimum number of children that GP residents need to see, just like if you were a surgeon taking out gallbladders. The only other option is to increase length of training, which I don't think anyone has much of a stomach for either. But to simply let this play out is going to, the situation will only get worse because the demographic change is not going to stop, at least not in my lifetime.
Right. We have another pediatrician, Stephen Herman, who's asking about the question, does the US data show decreased pediatric emergency department attendance in areas where there is a significant proportion of primary care pediatricians?
That's a great question. We have in America two issues related to that. Number one is after hours care, and the different venues for after hours care can be exceedingly limited in certain arenas. And for, just as in Australia, where there's a certain percentage of parents who think their kid's too sick, even though they don't have a serious illness, they're going to go to the emergency department. That happens in America also. What we don't have is an increasing referral to emergency departments. We definitely have, attendance in our pediatric emergency departments, no question, but it's not a referral issue. It's more of a parental anxiety issue. And people in America are crazy. I think y'all already know that. That's like not a secret. And parents are crazy too, but I think parents are crazy everywhere.
Right. You suggested that 1 year of additional training would be an option that you would favor. How would that work? At what stage of training would that kick in?
So in Australia, again, it's just mimicking something that already exists, for obstetrics and for geriatrics. And I think there may be something else, I forget what it is, that they have an optional extra year. But it would be at the end of registrar training where where if I was going to design it, my suggestion would be that GP registrars that 4th year, they would spend time in outpatient pediatric care. Like they'd spend time, not in the hospital, not in the ICU or in the NICU. They would spend time in a general pediatrics outpatient clinic, cardiology outpatient clinic, pulmonary outpatient clinic, where they would learn outpatient medicine or be exposed to it at least to know when to refer, when not to refer, and honestly, how to handle many of these conditions that they can handle in adults.
Right. Now, another question which really arises is looking at outcomes. And if you look at outcomes, are there changes in the proportion of negligence cases involving children? Obviously, you'd have to exclude the neonatal ones from this remit, because presumably those are linked to obstetrics. But are there changes? Have there changes occurred which may
No,
reflect a decreased education?
not to my knowledge, but I would say that's a very blunt instrument, that you'd have to have a real tragic outcome to have a negligent case. I would hope we don't let it get to that point.
In America as well, is that also the case?
Oh, we have people who sue like crazy here.
Yeah.
There's no correlation between malpractice and malpractice cases in America. It's
Right.
the number of personal injury lawyers in a given state, and whether or not large judgments or settlements are made. And because most are settled, they don't go to court, it's really unclear to be able to follow those numbers.
Right, which brings one on to the General Medical Council, which brings one on to the fact that Terence Stevenson, of course, was a pediatrician who was president of the General Medical Council. And a colleague of mine who's no longer alive, Frank Wells, and Terence campaigned very hard for the fact that research needs to be done in pediatrics, and that particularly their angle on doing this was that research involving the testing of medicines needs to include pediatric patients.
That's true. We do a terrible job in the United States with that as well.
And is there any indication that either the UK, Australia, or Netherlands are doing better at that? And
no.
And Terence, from his current hat, adds on to that isn't embedding some research component into the pediatric general practice sector going to be an important way forward for the future?
I think that'd be great. I would just love for them to feel more comfortable and confident in the care of children. And then on top of that, your mouth to God's ears, they should then do the research there.
Because are there trials going on, clinical trials going on in Australia in pediatric settings?
There are some, but again, children are always the afterthought. And quite honestly, for whoever asked, is it a business decision? That's not where the market is. If you're developing a new drug, you're not making good business decisions if you're focused on kids. So there's got to be some other political solution that creates an incentive. In America, if you do clinical trials to get indications for pediatric indications for certain medications, you could get an extension of your patent, because otherwise it's not worth it to pharmaceutical companies to want to do that because the market's too small. And right, as we know, becoming proportionately smaller, as we've discussed.
Yes. Well, I think we've had several questions, and they cover a range of areas, but I think all of them have said that they think this has been an excellent presentation of something that we kind of sense, but are not necessarily focus on. And thank you very much for doing that.
My pleasure.
And we look forward to hearing what outcomes are, maybe less blunt than the ones I suggested, but what outcomes are. And in 10 years' time, hopefully, there will have been a change and a shift towards better care for children.
Olive.
Thank you very much.
All right. Thank you. Good night, y'all.
Good night.
Bye.